Assalamu alaikum, it's me Dr. Muhammad Naseem Shirzad, and today I am trying my best to present the topic of transurethral resection of the prostate called the TURP. TURP is a very lengthy topic and a lot of discussion can be done on this topic, but I myself trying to just highlight the most tricky and important and academic point. So TRP, as you know, means the transurethral resection of the prostate, and it is commonly performed procedure for the benign prostate hyperplasia. And you know that TRP is the gold standard procedure to treat moderate to severe LUTs in men with prostate size of 30 to 80 ml. And it is also important just to overview the most important or absolute indication of TRP, and that's include recurrent urinary retention, patient having recurrent UTI, patient having acute urinary retention, patient presenting again and again with recurrent hematuria that is refractory to medical treatment with 5-alpha reductase inhibitor, patient develop complication like a bladder stone, or the patient presenting with renal failure. So in all these conditions, there should be no chance of trial or no chance of medical treatment to be given, but straightforward to plan the patient for TURP. The relative indication include if there are morphological changes in the bladder or upper urinary tract secondary to bladder outlet obstruction, constant and increasing post-void residual of greater than 100 ml, recurrent urinary tract infection secondary to bladder outlet obstruction. The final decision also depends on the patient willingness for the surgery. So these are the relative indication for TURP. Now let's discuss the contraindication of TURP. The absolute contraindication for TURP is active urinary tract infection or the patient is having uncorrected coagulopathy. The relative indication if a patient is having large bladder stone, two-stage procedure like cystolitholepexy and TURP can be performed, or the patient having anesthesia contraindication, or the patient having acute renal insufficiency secondary to bladder outlet obstruction. But now, before going to discuss the further detail, let me discuss with you all the various part of the resectoscope and the instrument using for TURP. So it consists the first in this picture, the first which is shown, that is the telescope, and we are using for TURP 30-degree telescope. And the next in the picture is the working element, or we call it the operating element of resectoscope, or we call it the working channel. So this second picture is actually the working element, working channel, or operating element of the resectoscope, where we will be attaching the cutting loop. The second is the obturator. I will discuss the different type of obturator in next slide. And then the last two picture, one is the inflow channel and the other is the outflow channel. This whitish area of the at the end of this inflow channel is called ceramic beak, and I will discuss it in next slide too. As a good practice of the assembly and disassembly of these resectoscope is important. Now this is the assembled resectoscope, and all these part I have already discussed that it consists of the telescope and then the light port where we connect the light source, and then it contain the electrosurgical contractor, means the dithermy will be connected at this portion, and then the inflow and outflow channel, and then it consists of the rod and the working element, and at the end it consists of the loop. So these are the various part of resectoscope. So as I have mentioned in this slide, these are the four parts, important parts of the resectoscope. that consists of the outer and inner sheath. It consists of the bridge with inflow and outflow channel, and then the telescope, and then the working channel, or we call it the elements with receptoscope. As I have said, that the ceramic beak, which is a whitish area, that is important is an insulating or a non-conducting material, and it is used for insulation purpose to resist the current of diathermy, to not spread it behind and not to damage the urethra. That's why this ceramic beak is placed at the tip. As I have highlighted this whitish is the ceramic beak, and it is a acting a non-conducting or insulating, not to spread the current, just to ward the urethra and not to cause iatrogenic injury. So this is important. As I mentioned earlier, that there are three types of the obturator. The one is the weaving obturator, the other is the straight descending obturator, and the third is the hinged or timber leak obturator. The timber leak or the hang obturator is having a hanging portion at the tip, and the purpose of this hanging portion, when you are inserting the scope blindly, this will help to manipulate or away the obstructing median loop from you. So this deflecting part of the timber leak, or we call it a hanged obturator, is important to away the obstructing median loop from your insertion. So in this slide I have shown the standard cutting loop. This is first picture is the standard cutting loop. The next is the blunt curette. We are not using that much, but we are using much of the time the standard cutting loop. And then this is a colon knife, which we are using for like in transurethral incision of the prostate. And then the ruler ball, which we are using for getting the hemostasis. So it's important. This is called the button electrodes, and this is used this is actually a bipolar button electrodes, and it is used for transurethral vaporization of the prostate. This is the loop which are using in bipolar TURP, and having a neutral part just near the loop, and the current just moving around this loop. That's why there is no need of neutral fat to be applied to the thigh of the patient. Now let's see how the bipolar technology is actually working. We know that for bipolar TURP we are using normal saline. So once the high frequency current applied, it reached into the active electrodes in the loop, and then the current from the loop is transferring into the conducting irrigants, into the normal saline, and in the normal saline they form a plasma effect. And you know that the tissue cutting is not because of this conducting this active electrode, but because of this plasma effect. This plasma is actually causing the cutting of the tissue, which is different from that of the monopolar TURP. So the current passing into the electrodes, from electrode it passing into the plasma, and this plasma is actually causing the cutting of the tissue. So the electrode is not directly involved in the cutting of the tissue, but this plasma effect causing the cutting of the tissue. Now opposite to the monopolar TURP, for which we are using glycine, as you know that the color electric current passing into the loop, and from a loop it passing into a non-conducting irrigant called the glycine, and after that the tissue cutting occur by the loop, not by these non-conducting irrigants, and from the tissue the current passing into the indifferent and electrode, which we have applied on the leg or thigh of the patient. Now it's important to understand the bipolar TURP setting. The bipolar TURP setting, we are applying that a low cutting energy of around 80 to 100 watt, and in patient who having a pacemaker, this is the best choice to use a bipolar. And if there is no bipolar available and you want to use the monopolar, better to consult the cardiologist for the setting of the pacemaker. The setting for monopolar TRP is the cutting current for monopolar is 120 volt and the coagulation current is 80 volt. Now the irrigating fluid which we are using for bipolar and monopolar TRP, for monopolar TRP we are using good irrigating fluid, the 1.5% glycine, which is actually a non-ionic fluid, and each 100 ml of contain 1.5 gram of glycine, and this solution is electrolytic, means this is non-ionic and it is hypotonic, having osmolarity of around 200 milliosmol. That's why there is a risk of TR syndrome in performing the monopolar TRP. But regarding the bipolar TRP, we are using 0.9% saline. That's why, which is isoosmolar and it is ionic, so there is low risk of TR syndrome by performing bipolar TRP. So now let's discuss the various method for TRP. But before going to start these various methods, it is important to perform a cystoscopy before starting the resection of the prostate. Better to assess the urethra, then go forward and assess the verumentanum, and then assess the lobes of the prostate, and then make a plan, and then after that better to identify the both ureteric orifice, and if there is any pathology in the bladder, try to assess whole of the bladder. Then after that plan your resection. So it's important to first perform with 24 FR cystoscope with 30-degree lens, and then assess the urethra, then assess the bladder neck, then assess the verumentanum, assess the ureteric orifice and any pathology in the bladder. Now these are the various method for TRP, that include the Burns method, the Nesbitt method, the Alcock and Plock technique, and the Marmer technique and the Blandu technique. It's all about the surgeon, that from where he want to start the resection, and all these procedure is just telling us from where to start your resection. So the resection is all about the surgeon preference. For example, in Nesbitt we are starting our resection from 12 o'clock, and then we are going to the lateral lobe from top to bottom. The median lobe will be the last to resect. So this is a Nesbitt method. The other is the Burns method, which is totally opposite of the Nesbitt method, and in which we are starting from the median lobe, and then we going to start from the lateral lobe. The lateral lobe resection is started from the top, from the bottom to the top, and many of the surgeon is using this Burns method as the justification behind the removal or the resection of the median lobe first, is that you just removing the part of the prostate which is much of the time is the obstructive portion, and that is the median lobe. Second, the removal of the median lobe will help you to give easy swabs from the prostate, and the chips will not coming on your face. The second important thing is, if the prostate is having asymmetry, like the right is large and the left is small, better to resect first the larger lateral lobe. So in right or left selection, better to go for the one which is the larger. And again, the reason, if any complication occur during the procedure, you can stop the procedure as you have resected much of the obstructive portion, like you have resected the median lobe, you have resected the lateral lobe. So that's why it is important to first start from the median lobe, and it will give you multiple benefit, like you have removed much of the median lobe, which is the obstructive portion. It will be easy for you to enter into the bladder easily. The chips will not coming on your face, and your irrigation fluid will be easily going into the bladder. Then the lateral lobe start from the one which is the easy for you, which is the large one. And the second important thing is to start either from interior to posterior, I means from outside to inside resection, or from inside to outside. Again, that's also depend upon the preferences of the surgeon, many justifying that better to start from the inside to the outside, and many saying better to start from outside, I means from interior to posterior. And they are saying that if you are performing from interior or from outside to inside, the chips that you are cutting, that will not be coming uneven pace. So, and second, when you are starting from outside, you will identify the bureau and then you will go toward the bladder. So this is the inside and outside resection method. So this is the Burns method is used by many of the surgeon. And now the third procedure is the Alcock and Plock technique. And this technique we are starting from 9 and 3 o'clock, and then it's depend upon the situation that which lobe is large, as I have shown this in this picture. The third is the modification, the fourth is the modification of this procedure, which is called the Marmot methods. And this is actually the modification of the Alcock and Plock method. And just like the Bones method, we are starting from the median lobe, but after that we will be resecting at 3 or 9 o'clock. And this is method is recommended for the much of the beginner and could be used for large and small adenoma. The last method of TRP is the blended technique, and in blended technique there is the identification of the landmarks, and then we resect the middle lobe, and then we take control of the Plock artery, and then resecting the lateral lobe. Now there are some important few questions that you can face during TRP, like during your clinic you can receive a patient from other department where they are planned for the hernia repair. If you assess the patient and he is a candidate for TRP, so first perform TRP, then the hernia repair, as the enlarged prostate is the reason behind the hernia. So first try to treat the cause, then go for the hernia repair. And now it is not uncommon to incidentally detect the bladder stone. So what to do in that scenario? If you are planned a patient and during cystoscopy you found a bladder stone, so at that scenario, if the stone is small, better to perform cystolitholopexy, and in the same sitting go for TRP. But if the stone is of a large size and you are thinking that you are unable to perform both in one sitting, then go for cystolitholopexy and then go for TRP in next list. Same, it is also not uncommon to incidentally detect bladder tumor during TRP in men with benign prostate hyperplasia. Provided these tumors are papillary rather than small and not extensively multifocal, it seems feasible to resect these tumors and continue with the resection of the prostate. So simultaneous TRBT and TRB does not appear to lead to any increased risk of tumor recurrence or progression, according to AUA guideline 2023. So you can perform for a small growth TRP and TRBT in same setting, but if the tumor is large, then take a biopsy of the tumor and go for TRP, and then plain TRBT in next sitting. The other scenario which you can face, if you have planned the patient for TRP and you found some soft structure, better to catheterize the patient by incising the structure and plan the patient for TRP in next list.